All right, we are going to get started. This is our week 7 call. This week, we are going to do filler recap. Okay, so this week we're going to talk about filler. We're going to see if anyone has any questions over just general MFL operations. We're going to go over any AR questions anybody might have, and then our marketing ideas for the week. Let's get started. Okay, so quick recap on the major blood vessels that we need to know. It starts at the external carotid. So you're the external carotid. And as it travels up to the face, you have your facial artery, and it comes out of a little foramen that sits right in front of your masseter muscle, and it travels to the upper face, and then it hits the angular artery. Once you hit the angular artery, then you're going to continue to travel up where it turns into the supratrochlear artery. Another artery you need to be aware of is the infraorbital artery and the transverse artery. Obviously, the lips are the superior labial artery and the inferior labial artery. The superior is on top and the inferior is on bottom. Why is this not? There we go. Why does it take me to this? Not what I want. Sorry, all the it's not pulling up my filler recap. I don't know why. Let's try this again. Can y'all see my screen? Great. Okay. All right. So we are going to be going over Danessa, you might be in the wrong group. Do you know what week you're on? Oh, sorry, I can't hear you.
4.
Okay, yeah. You start in 1 hour.
Oh, I thought it was at 8 o'clock. Okay, just kidding. Sorry,
Yeah.
bye.
All right, bye. Okay, so we are going to be reviewing dermal fillers. Okay, so all the dermal fillers that we are going to be using within MFL are hyaluronic acid fillers, and so that they can be dissolved by the enzyme called Hylenex or hyaluronidase, which is the generic term. There are other types of fillers on the market. You have Radiesse and you also have Sculptra. They are chemically made a little bit different. However, they both are collagen producing fillers. Sculptra kind of lays seeds, where Radiesse more helps you build your own collagen in a different way by activating a different mechanism. The fillers that we use come in either 1 or 1.2 mLs. They do each come with 2 needles as well. Now, what can dermal fillers do? Essentially, the purpose of all dermal fillers is to add volume back into where volume has been lost. So in the mid-face, nasolabial fold, lips, things like that. So it is a gel that is going to add volume back where it is gone. Those are the 3 different types of fillers. We only really carry the hyaluronic acid fillers. Quick recap on G prime. G prime refers to how thick or stiff the filler is. The higher the G prime, the thicker the product is going to be. So if you want to treat someone's mid-face, you need a product that can handle the mid-face and all the tissue. So you need a product that has a very high G prime, where a product that you're going to put in a patient's lips, you can go with a low to medium G prime product. So that is why G prime is important, because it helps with filler selection. Already kind of did a quick recap on the facial anatomy and the major blood vessels that we need to be aware of. The biggest thing that you need to do is to make sure that you aspirate anytime that you are injecting filler. Aspirate at least 6 seconds. I literally did a paraform a couple days ago on someone, and I went all the way down to the bone where I always go, where you are told that you were traditionally pretty safe. And I aspirated and immediately got bright red blood back. I was 100% inside of her angular artery. So always aspirate. I pulled the needle back, I held pressure, I readjusted and injected in a different spot, and the patient was great. And I also patted myself on the back for finding it. These are the different layers of the face. So whenever you're injecting, you want to make sure you're choosing a product that can go into that specific layer of the face. You would not want to choose a really high G prime product that would put it in layer 1. It would just, you would see it and it would not look good. You want to put a really high G prime product like Restylane Lift, RH4. You would put that really in between 6 and 3. So around 4 or 5 is typically where you want to lay those products. These are the major fat pads of your face. As we age, they start to separate and disintegrate. That is why you start to get volume loss as you age. At the age of 35 is really when this starts to take place. That's when a lot of people will start to realize that their face is starting to kind of fall. And it's because those fat pads are separating and disintegrating. And that's why if someone says that their tear troughs are bothering them, always look at their mid-face first. Fix their mid-face deficit before you go and try to fix their tear trough, because the majority of the time when you fix their mid-face, it will add enough volume back into their mid-face so it kind of hides that shadow or that shelf of the tear trough. Tear troughs tend to be way overdone, and a lot of times you can just correct what the patient needs to be corrected with doing mid-face only.
Are the tear troughs usually corrected with Botox or with filler?
Filler.
Filler.
Yeah. And because it's such a hydrophilic area, it swells a lot. So whenever you ever do someone's tear troughs, it's literally like half a syringe on each side. Like it's never one syringe. I mean, it's very, and even then I might do like a quarter on each and then just be done.
Does a patient pay for the whole syringe even if they use half, or do they just tend to pick different areas to put it in?
Yeah, just use it in other areas of their face.
Okay.
Yeah. So if I'm doing someone's lips and I'm like, oh, like we did someone's lips the other day and we were pretty much done. She didn't need any more volume. We still had 0.2 left. And so we went and put it into her paraform. As your fat pads start to disintegrate, so does your bone. So if you have a little lady kind of come in, you want to make sure that they're not having major loss of bone in the mid-face, especially if you're going to be going all the way down to bone. That's the only reason why that's important. So just kind of be cognizant of that, especially if you have a patient older than 70 years old.
Do you tend to have to do more in somebody who's older?
I have to usually do a different type of product. I usually use RH4 with them versus Restylane Lift, because their skin starts to get really kind of thin as well. And the really high G prime product like Restylane Lift is the highest G prime. If you put that in someone who's like 65 years or older, then their skin it's going to look like rocks underneath. So that's why I like RH4 for them.
And RH4, sorry, is a lower G prime?
It's a smidge lower.
A little lower, okay.
Yeah, it's a smidge. I mean, it's still considered high G prime, but it's more of a rounded product versus like sharp peaks. So think like Appalachian Mountains versus Rockies.
And then like how much volume will you typically use if you're just doing cheeks? Will you need to have 2 syringes or one will make?
I usually start with 1 and I do half on half and I see where we're at. If the patient can handle more, then absolutely I'll crack open another syringe. But I usually will only do half at a time on a patient's face.
Gotcha. And then you can repeat it. Maybe you'll talk about that. I don't know when you can.
Yep, and then
Repeat it.
Yep, you repeat it. So you can usually, if the patient, if you do that one syringe and you're like, yeah, you can absolutely need more, then you can crack open another syringe at that appointment and you can do it. Sometimes I'll make the patient wait 2 weeks to see how the tissue will
Okay.
heal, and then I can go and add more. Before you do the filler, you have a little checklist. You want to make sure that they try to avoid NSAIDs, high doses of vitamin E, a lots of alcohol before, coffee, green tea, things like that can theoretically thin the skin. No vaccines for at least 6 weeks before or after. Those are not like absolute contraindications. They're just kind of more to help prevent bruising. But the major contraindication is going to be if they're on a blood thinner, then it's a no-go. If you are doing somebody's lips and they have a history of cold sores, you do need to call them in. Valtrax 2 grams PO/BID times 1 day.
Are they just using it if they outbreak, or they go ahead and use it?
Go ahead and use it prophylactically.
Oh, gotcha.
Because if they really do break out, it will cause a breakout. Okay, sorry. Okay, the biggest side effects is going to be obviously bleeding, bruising, infection. The same thing as filler, as neurotoxin. The big one is going to be a vascular occlusion that is considered a medical emergency. If you do have a vascular occlusion, things that would show up would be a reticular pattern, like a reticular lacy pattern, blanching, a grayish hue of the skin, pain plus or minus. Pain is not always there. Remember, you do have 2 types of vascular occlusions. You have an interarterial vascular occlusion, meaning you accidentally got it into the vessel, but then you can also have a compression vascular occlusion where you got it too close or swelling has caused compression of the vessel, and then the blood flow is not getting through. Obviously, a compression VO is significantly easier to treat than an interarterial one. So if you do just have a compression, you kind of flood the area and massage. If you do have an interarterial one, you do have to cannulate the vessel to get it. Another absolute contraindication is going to be if they're allergic to lidocaine. If they're allergic to lidocaine, the majority of the fillers come with lidocaine already in it. So if they do have a history of allergy, a couple of them you can request that are lidocaine free, but for the most part, they have lidocaine in them. The biggest thing is going to be to aspirate. I always say count to 6 Mississippi, follow basic anatomical landmarks. Make sure that you know that obviously every single person is different. Look for color change, ask the patient if they're having any pain, and do you need to call any acyclovir or anything prophylactically for the patient. You want to make sure that you are injecting slowly with retrograde injections. You want to do at least no more than 0.2 in each injection point, really 0.1. The only place that can handle 0.2 is going to be in the mid face whenever you are doing cheeks. Really anywhere else, you should never bolus more than 0.1. I'm not going to go over this. Talked about retrograde. These are the different injection techniques. Whenever I'm injecting, I do a lot of cross hatching and I do a lot of fanning. I do all of my injections are retrograde though. So I will go in from one port if I'm going to fan, and I'll go up, and I'll usually do, 3 to 4 different threads kind of, just like this on top of each other. If I'm going to do cross hatching, then I'll do the same thing and I'll go above this way. And it just kind of helps create structure. I do that a lot in the nasolabial fold. Nasolabial folds, you really want to look at the mid face first and see if they need to have their cheeks done before you do their nasolabial folds, because you just don't want to keep filling here and here and here. You want to try to give them structure here and then go and fill here. These are the marionette lines. These are also caused from volume loss, and as it comes down, the nasolabial fold and the marionette lines form. Again, by fixing that mid-face, it's going to help the marionette lines significantly. If the patient doesn't have enough improvement, you can always go back and add a dedicated filler right in this area. There's a lot of major blood vessels right there, so you make sure you aspirate, and usually I tell people to use a cannula as well. All right, for lips, the way that we taught y'all to do lips is going to be the line and fill method. So whenever you are injecting a patient's lips, I usually draw on the patient's lips with my marker clean them, draw on their lips so I know exactly where I want to go. That way, if I'm standing above the patient, I don't lose sight of where my lines are. So line the lips first, and then you can go back and add the pillows as you are injecting. This is the basic anatomy of the lip. Again, this is just a recap from the live training. You have your Cupid's bow right here. You have your philtrum columns that kind of go up towards the nose. You do want to make sure that you define the patient's Cupid bow and the philtrum columns if they need it. And then you're going to define that vermilion border, and then you're going to go and fill the belly of the lip. The golden ratio is 2/3 to 1/3, meaning that the bottom lip is traditionally 2/3 larger than the upper lip. However, the younger generations, they are liking that more 50-50 rule. So they're wanting that upper lip to be the same size as the lower lip. So just ask your patient kind of what they're looking for. There are lots of different techniques that you're going to hear about. You're going to hear about the Julie Thorne technique, the Russian lip technique. Essentially, all of it is fencing, where they go in from the vermilion border and they go straight up through it, lay a little aliquot of product, and then pull it straight down. So the fences are vertical lines that are going through the vermilion border. It is considered an advanced technique because that's where patients will get a lot of that shelf look, and it's because they went above that vermilion border and instead of directly on it. And it can give the illusion that they have a shelf. So it's considered a very advanced technique. The people that don't do it correctly are leaving little shelves. That's why we like the line and fill method. For the mid face for the cheek, remember we drew our 3 lines. You're going to go from the pupil straight down, the lateral canthus straight down, and then from the tip of the ear to the tip of the nose, and you're going to cross over. I usually draw a dot at the apex of the cheek. That's the highest point of the cheek, the most projection point of the cheek, and I want to make sure that my line crosses right there. I'm then going to go 1 centimeter over from that lateral pupil line because you do not want to hit that infraorbital artery. I go directly down to the bone and I do 0.2 after I aspirate. Then I go 1 centimeter over and then I do 0.1. And then I go over another centimeter and I do another 0.1. So 0.2, 0.1, 0.1. Whenever you get a little bit more advanced and you start going into other areas, the chin is a really great area to go. It is a very easy area to do as well. Usually when you do a patient's chin, you want to make sure that you are staying within the female and male anatomy, or the feminine and masculine anatomy. For females, what is considered to be more feminine is to have a more narrow chin. So you do not want to go past the nares. Okay, so the nose, you do not want to go past it. So you want to draw a line straight down, and you want to make sure that you're keeping product right in that center. However, where the more masculine features, they actually go all the way out to the oral commissures. Okay, so that's a little bit more of a wider chin. I think that's actually what Jennifer Anderson did, is whoever did her chin, either augmentation or filler, they went too wide. And that's why her chin, that's why she has been taking on more masculine features, is because of that. So you do want to make sure that you're staying more narrow just to follow the normal female anatomy. Tear troughs has to be done with a cannula. So usually make a hole right in the center, and you're going to feed it up into the cannula, up into the tear trough area, aspirate, and it's literally a quarter of a syringe on each side. It's a very, very little product, and you can kind of just lay a little line right here and then take your finger and kind of smash it down along that orbital rim. Sometimes I'll take a little insulin syringe and I'll go along this orbital rim if they need small little touch-ups just around there. And I will backfill a syringe. All of this is in your PowerPoint presentation that you were given. Jawline, it's another really kind of fun one to do. With the jaw, you do have to use a lot of product. I do use a cannula for the jawline. So I'll usually just do a little pilot hole right here, and I'll go all the way back. More masculine features is to have a sharper angle, where more feminine is going to be a wider angle. So masculine is going to be more of that, like almost 90 degrees or so, where the female one is going to be significantly larger than that. So it's a little bit softer looking. Post-op, kind of very similar to neurotoxin. The biggest thing with this is to not massage the area. Some people, they hear that, oh, you're supposed to massage it after you get something done. We put the product exactly where we want it. It is a gel. It can be moved up to 24 hours. So please tell your patients to not massage the area. If after 2 weeks, I always tell my patients, don't love it or hate it for 2 weeks. If they do have any lumpy or bumpiness at that 2-week mark, I tell them now you can start massaging at 2 weeks. You're going to do it twice a day. Every time you brush your teeth, you're going to just do a little massage, and you're going to do that for 2 weeks. So then if after that final 2 weeks, they still have anything, you needed to do some dedicated dissolving of little lumps and bumps, now they are 4 weeks post-treatment, and that takes care of 99.9% of all little nodules in there. So make them wait 2 weeks. I always tell them, don't love it or hate it. If they have some nodules at 2 weeks, you need to massage twice a day for 2 weeks, reassess. If they have anything, you can do a point little dissolve what you need to. Check, I don't know how to. We went over vascular occlusion in training pretty extensively. We talked about how a vascular occlusion can look like a bruise, but the biggest thing is it's going to getting progressively worse. The patient doesn't always have to have pain. It can be associated with it, but it's not always, but it will be traveling up. So it's going to be that duskiness, that reticular lacy pattern that you see like on this nose area, or if it's following the vessel. Those are obviously big concerns. And then blanching is a big one as well. So this is an obvious vascular occlusion. They hit the inferior labial artery on this one. Anytime that you inject filler, you must have your crash cart on you, which is Hylenex. If you do not have Hylenex in your bag, you are not allowed to inject filler. So make sure that you always have at least 1 to 2 Hylenex in your bag at all time. In Virginia and in the other states, if you do ever run into a VO, you are never alone with a vascular occlusion. You have a whole team behind you. If one of us needs to hop on a Zoom or, do whatever we need to do to help you walk you through it. And if it still cannot be resolved, we have connections in all the states. And if we need to, we can obviously, all of us will be on an airplane for the people that are in Virginia or Louisiana. And that is our vascular occlusion protocol. If you do have a patient with any visual issues, if they do start having change in vision, you must take them to the closest big hospital. This is not a rural hospital. You're going to take them into like the center city hospitals, like downtown Richmond, downtown Houston, downtown Dallas. You're going to a large hospital. Treating infections. If they do get a cellulitis, the person that did your telemedicine can call you in your prescriptions. If you're an RN or NP or PA, you can call in an appropriate antibiotic for cellulitis. Keflex is a great one. Clenda is a great one. Some people just do Augmentin. There's lots of different antibiotics that you can choose. Just follow your local antibiotic gram. Delayed onset granulomas or delayed non-inflammatory nodules. These occur while the product is breaking down around 6 to 9 months after the patient has been injected with filler. The biggest way to present it or to prevent it is going to be product selection, patient selection, and also hygiene while you are injecting. Remember, the theory behind it is you accidentally inject a bacteria and it forms a biofilm around that little bacteria and it forms a tumor. It is self-limiting, but it is pretty distressing for the patient. If someone does have a true hypersensitivity reaction just like this, we can call in some prednisone for the patient. We usually do 60 milligrams PO BID times 1 day, and it usually takes care of it. And that is it for the recap. Any questions?
I don't think so.
All right. Do you have any questions at all about any MFL operations?
No, I'm having my lunch party soon. It'll be January 6th. So
Perfect. That's exciting.
I think I traded some emails to get the equipment
Awesome.
or the supplies sent. I think
How many people are you going to invite?
I already invited quite a number, but my definites that are doing it
are probably somewhere between, I want to say like 4 to 6, maybe.
Excellent. Aim for 6.
And then there'll be people just kind of dropping by to check it out.
Yeah.
Hopefully it won't be too much of a distraction, but
Okay, perfect.
and then I'm just working out the timing of it because everybody's kind of busy with their kids' activities.
Yeah,
So,
Yeah. perfect. Alrighty, well, no questions. Let's go on to AR. Do you have any questions with aesthetic record? And you may not yet, just because
yeah, I think
party.
that's
when you get to your launch party, there's lots of different videos and things that you can watch.
okay.
You know,
Yeah, I was planning on.
make a fake patient. You know, you can play with your own account and do all sorts of things. We just ask, don't check yourself out, obviously.
Yeah.
Yeah. Don't put your credit card in there and check yourself out. Don't do that.
And then most people just do it on your phone. Is that what you do?
Yeah,
Okay.
we all do it on our phones. Yeah. A couple of people have an iPad. I feel like iPad, for me, I don't like it, but other people swear by it. So it's just whatever you're more comfortable with.
Okay, yeah. I think my iPad's kind of old, so I feel like it kind of shuts down quick.
Yeah, same. Yeah. I had an old one that my children use, so I didn't like it.
Yeah.
All right. So this week, for marketing, you are going to do a Facebook or Instagram live, and it can be or reel. So those are little videos that you just kind of post on your group page. You're also going to post a before and after of cheek filler. I have one for you. This is not something that you can do until you take a second filler training, but it is good to start kind of getting some feedback and just putting some feelers out there of who might be interested. And then you're also going to do one education post about how the face ages. And so that's where you're just going to, that's something that you will develop yourself, and you'll talk about how the fat pads in the face separate. It starts at age 35 and they start to kind of disintegrate, and that's where volume loss happens. Again, that's a post that you're going to come up with on your own. And then we came up with 2 more people for you to follow on your social media, aesthetic_injector and injector Kens. Both of them are great accounts to learn from, so highly recommend both of them. All righty, and that is it for our call today. Do you have any questions? Excellent. All right, well, I hope you have a wonderful evening. I hope you feel better. All right, bye.